So good afternoon, everyone. Can you see my slides? Can you hear me?
Very well, very well.
Okay. First of all, I'd like to thank the organizers and especially Dr. Iakovou for their kind invitation. Apologies for not being there. Hopefully next year we'll be able to join you. So, while transfemoral access remains the primary route due to its lower complication rates and favorable outcomes, a subset of patients have anatomical or clinical factors precluding this approach. For these patients, alternative access routes such as transaxillary, transcarotid, or transcaval provide viable options. The STS-SEC TVT registry is the largest national registry that includes all consecutive TAVI procedures performed in the United States. TAVI volumes have increased every year, exceeding surgical AVR in 2019. At that year, femoral access increased to 95.3%, while alternative non-femoral artery access remains necessary in 4.7% of TAVI procedures in the United States. The extrathoracic approaches, transcaval, transcarotid, and transaxillary, appear preferable over intrathoracic approaches when femoral access is unsuitable for TAVI. A recent meta-analysis compared extrathoracic versus intrathoracic, in other words, transapical and transaortic approaches, in 18 studies published through 2023. More than 5,000 patients treated with extrathoracic TAVI were compared with 6,800 patients who underwent TAVI, intrathoracic TAVI, and intrathoracic access was associated with an increased risk of all-cause mortality at 30 days and 1 year, with a relative risk of 1.99 and 1.31 respectively. Intrathoracic access was also associated with a higher risk of major post-operative complications at 30 days compared with extrathoracic TAVI. This included new-onset atrial fibrillation or flutter, a higher risk of acute kidney injury requiring renal replacement, and life-threatening bleeding. Interestingly, there was no difference in stroke rates between these approaches. The hostile registry sought to compare clinical outcomes with transfemoral access, intrathoracic access, and extrathoracic approach in TAVI patients from 28 international centers. The patients had severe peripheral artery disease and hostile femoral access, and transfemoral approach was either impossible or possible only after percutaneous treatment. The primary endpoint was the propensity-adjusted risk of 30-day major adverse events, defined as the composite of all-cause mortality, stroke, or main access site-related vascular complications. Among the 1,700 patients included in the registry, 510 patients underwent TAVI with transfemoral access after percutaneous treatment, with intrathoracic 642 patients, and 547 patients with extrathoracic, mostly transaxillary approaches. Compared with intrathoracic approach, both transfemoral and extrathoracic access were associated with lower 30-day rates of major adverse events, driven mainly by fewer access site-related complications. Transfemoral access compared with extrathoracic was associated with lower 30-day risk of strokes and TIAs. Both transfemoral access and extrathoracic access were associated with lower rates of major bleeding and access-related major vascular complications compared with the intrathoracic access. This slide shows yearly trends in alternative non-femoral access routes for transcatheter procedures broken down by device manufacturer Medtronic and Edwards. Once dominant, transapical and transaortic access with the red line has sharply declined and now accounts for less than 10% in both graphs. This reflects a clinical shift away from more invasive access methods. Transapical and transaortic access is being phased out, likely due to a higher complication rates and invasiveness. barely used in 2015, transcarotid access with a light blue line has significantly increased. Now, the most common non-femoral access for both Medtronic and Edwards by 2023. Axillary and subclavian access with a dark green line was a major approach, especially within 2015, but has gradually decreased in use across both companies. This field is so the field is moving toward a less invasive and more vascularly accessible route, particularly transcarotid. Imaging evaluation of alternative access is of paramount importance. To optimize image quality and contrast and radiation dose, a two-step strategy is preferred: an ECG-gated volume scan of the aortic root and heart, followed by immediately afterward by a non-ECG-gated scan of the vasculature, including the neck, thorax, and abdomen and pelvis. This can be achieved using a relatively small amount of contrast administered once before the two combined acquisitions. The axillary artery is an attractive route due to its extrathoracic location, relatively ease of surgical or percutaneous access, and is of sufficient size of TAVI delivery systems. The left axillary artery typically allows more favorable delivery angles relative to the aortic valve, appears less tortuous, and preserves the innominate artery for cerebral embolic protection if necessary. And relative contraindications to axillary artery access include an ipsilateral internal thoracic artery as a graft to the coronaries, or an axillary artery diameter 2 millimeters smaller than the expanded TAVI access sheath diameter. Transaxillary access may cause greater radiation exposure to operators compared to the transfemoral approaches. Here are the most representative observational studies of transaxillary access approaches for TAVI that included more than 5,000 patients. The 30-day death rate was 5%. The 30-day stroke and TIA rate was 6.2%, while the major bleeding was met in 11.8%, and the major vascular complications was 3.8%. But we have to keep in mind that these studies, they didn't include the cover stent implantation as a complication, which is common during transaxillary access. The ACCESS study, the largest prospective multi-center trial specifically for transaxillary access, provides important data on contemporary outcomes. It included a small number of 75 patients treated at 6 experienced centers exclusively with the SAPIEN valve. The access success rate was 97%. The vascular complications were 6.70%. Stroke rate 8%. Half of them were debilitating. The ACCESS study did not demonstrate any significant difference in other procedural adverse events, length of stay, 30-day outcomes related to right or left side intervention, or in patients who underwent a completely percutaneous approach or versus the surgical cut down. And this is a case from our practice that transaxillary route was used. A patient was transferred from another institution in a critical condition with acute heart failure on a CPAP. He had a surgical aortic valve replacement and the CABG 11 years before. The valve, the aortic valve, the Sorin valve was degenerated and had severe aortic regurgitation. Moderate mitral regurgitation was also noted. You can appreciate the severe eccentric aortic regurgitation in the deep transgastric view in the right upper panel. The vasculature of the left-hand side, common iliac, external iliac, and common femoral artery was diffusely diseased. There were underexpanded and undersized stents both sides. And after a discussion with the vascular surgeons, it was decided that it was better to avoid any transfemoral approach. And here was our procedural strategy: conscious sedation, 7 French slender sheathing to the left radial artery and the safety wire just to prevent any complications. Ultrasound-guided micropuncture and then an 8 French sheath insertion to the left axillary artery, single pro-style closure, a ladder vis for better support, and direct implantation of Olevolut FX 23mm valve. And finally, post-dilatation for stent fracture using an Atlas 22mm balloon. As you can appreciate, the size of the left subclavian artery was big enough in order to avoid any complications regarding the left internal mammary that was anastomosed to the LAD. And you can appreciate also the severe aortic regurgitation by aortography. And then the Evolut FX 23mm valve was deployed directly, post-dilated. Here is a transthoracic echo 2 days later, no paravalvular leak, a peak gradient of 18, and the moderate mitral regurgitation was reduced to only mild degree. The transcaval approach starts from the premise that the transcaval axis in a closed retroperitoneal space, the interstitial pressure exceeds venous pressure, so aortic bleeding can safely decompress directly into the venous system through the nearby inferior venous cava hole, rather than accumulate as a retroperitoneal hemorrhage. Femoral vein transcaval axis offers familiar transfemoral-like operator ergonomics and reduced radiation exposure compared with other non-femoral artery access techniques, and similar risk of iatrogenic stroke compared with the femoral access. And here are the representative observational studies of transcaval access, including a small number of 400 patients. The procedural success was 98%, major or life-threatening bleeding was 11%, transfusion was given in 35% of the cases. At 12 months, there was no additional vascular complications, so it's a decent technique for those who have the experience. The carotid artery is a convenient site for access owing to its extrathoracic location, size, proximity to the skin, and the ease of surgical exposure. And it can be used in cases as a good option for the non-femoral approach. There are several potential explanations for the similar or lower stroke rates with transcarotid access compared with other non-femoral access sites. During the procedure, the clamping of the distal common carotid artery and the flushing of the potential debris before unclamping may protect the ipsilateral cerebral hemisphere from emboli. And during the transcarotid access, of course, we avoid the traversing of the original of the vertebral arteries, which is also very important. And here are the studies, including 2,600 patients, 30-day death, 4%, 30-day stroke rate lower than the transaxillary access, 3.6%, and major bleeding, 6.3%. And here is a table with the head-to-head comparison of the 3-axis, the extrathoracic axis sites, the transaxillary with the blue bars, transcaval with the orange, and with the gray, the transcarotid axis. And the head-to-head comparison based on data from the TVT registry, just showing that the transaxillary approach is declining while the transcarotid procedures are increasing, lower stroke rates in the transcarotid group, as mentioned before. And the same when the data are coming from the use of the Sapien valve, lower stroke rates in the transcarotid axis, while the predictors of 30-day stroke were the prior TIA, porcelain aorta, peripheral artery disease, and subclavian axillary access. For the sake of time, I will pass this analysis, detailed analysis of the 3-axis sites, just to mention that there are no any specific recommendations on the alternative access from the guidelines of ACC and the ESC. However, the ACC guidelines, in recognition of increased patient and procedural complexity, recommend that alternative access be performed at level 1, or in other words, in comprehensive valve centers, while level 2 primary valve centers perform only transfemoral TAVI. In conclusion, Mr. Chairman, ladies and gentlemen, there have been important advances in delivery systems and techniques leading to approach the transfemoral access to be widely accepted. However, as the overall number of procedures are increasing, alternative access remains a significant challenge. New observational data with current devices have provided insights into the safety of alternative access practice. And in light of the limited available data, when femoral artery access is not suitable, extrathoracic access should be selected over intrathoracic, and transcarotid and transcaval approaches should be preferred over transaxillary access. Thank you for your attention.
All right, that was terrific. Thank you, George. This was amazing. And we're not going to have questions right now. We're going to go straight into the Cath Lab for an alternative